Good evening, everyone. So we'll start the webinar. This is first of the series of webinar that we plan to do revolving around digital pathology. So the first talk that we have is describing what is AI 100, what is SigTuple's AI 100, followed by an amazing, a great, enlightening talk by Dr. Bhagwat, who has been an old-time associate with SigTuple and who has avidly has used our device AI 100, followed by toxin malaria and some interesting case discussions. So I will begin with introduction to AI 100. Just give me a moment, I'll share my screen. So SigTuple is a homegrown company. It's based in Bangalore. It's a company that works on medtech solutions and largely revolves around pathology innovations, AI-enabled solutions in pathology. So their main focus is to automate the manual processes that we do in laboratory routinely. So that kind of brings us to, right now we are focusing on hematology, and recently we have launched a new product which also automates urine. So what is the idea behind the innovation that SigTuple is working on? So we want to automate the entire manual microscopic review because we know that it is prone to errors and at times very inefficient. When we automate a manual microscopic process, we are also digitizing that entire process. In lieu, what we are getting is we are getting an opportunity to democratize microscopy in the sense that then there won't be any borders in the diagnosis. We can scan a slide in Africa and review it in USA or in India. So the medicine will have no boundaries, the diagnosis will have no boundaries. It will disrupt the entire diagnostic system that exists right now. We currently offer 70% of solutions to this to digitization or automation of manual microscopy. But in future, probably in the later half of this year, we'll be coming up with plans which will cover more microscopic needs in a laboratory. So the first thing that we do, we know that 70% of the decisions, clinical decisions, they are based on diagnosis, on diagnostic results. So out of which hematology encompasses a larger amount of load that comes to our laboratory. On rough estimate, around 4 billion samples per year are screened in laboratory globally. So, and out of these, most of them are analyzed in hematology analyzers. 15 to 20% on average in any kind of clinical setup, in any kind of clinical laboratory, they flag abnormality and they require a microscopic review. So the microscopic review can be done, the slides can be made either manually or nowadays in some certain labs, you will find that these smears are made by auto smears and auto stainers. But then we have to analyze it on microscopes. So the major chunk of microscopy, the major method of microscopy is manual microscopy. Manual microscopy is a commonly used method. However, it is plagued with certain problems, and that is that it is time consuming, it is error prone, it is also subjective, sometimes inefficient, and sometimes inaccessible in areas where no experts are available. There's another solution to microscopy, another alternative way of doing it, which is digital microscopy. Unfortunately, the penetration of this modality is very, very less, around 4%, largely due to the cost that involves in buying such devices which enable digital microscopy. Next area where we can actively work on is urine analysis. So we know that like hematology, a urine sample is a commonly catered sample, is a common sample that labs cater to. So after a biochemistry analysis on automated analyzer, an in-depth analysis is done by microscopy. So again, the slide preparation, microscopic analysis, the problem is the same, that it is time consuming, labor intensive, it's subjective, error prone, and in areas where experts are not present, sometimes the results are erratic. There is another solution to microscopy other than manual microscope, which is digital microscopy and automated urine microscopy, which are available in the market. Again, the penetration of this solution is low because of the high cost. So what do we do in this scenario? So we introduce a device which is known as AI100. This is our flagship product. It's one device, but it has two softwares on it. So one is Shonit, the other is Shrava. Shonit is Sanskrit for blood and Shrava is Sanskrit for urine. So these are basically artificial intelligence driven softwares. They are nothing but algorithms which will take multiple pictures of the slide that you have loaded, it has scanned, and then through their algorithm, through analyzing those multiple images, they are going to give you an AI-based automated morphology analysis of WBCs, RBCs, and platelets if you are using Shonit as a software. And if you're using for urine microscopy, you're going to get AI-based detection and classification of abnormal urine samples. So what AI100 is offering you is multiple tests on single device. In the later part of the year, we are also coming up with a universal scanner, which will digitize almost any stain sample in laboratories. So AI100 offers accuracy, it is affordable, and it makes reports accessible because everything that is scanned is stored on cloud-based platforms in this device. So you don't have to have additional costs of bringing in an infrastructure which enables the operation of this device. So I've already explained it to you. There's only one hardware, AI100, which is basically a smart digital microscope. It will give you a 400x magnification, 20 slides per hour throughput, and it has two softwares, Shonit, which is going to scan all your peripheral smears. So what you need for using Shonit, that is automating peripheral smear, is a glass slide. Glass slide, which is used in your lab, whether you do a manual staining, a manual smearing, or you do an automated staining or automated smearing, it is going to scan any kind of slide that you produce in your lab. You don't have to bear any additional cost. Then this slide is scanned on the device and Shonit, using Shonit, the device analyzes this, and this is the platform. This is where you are going to see the entire report on your laptop or on your computer or on your tablet or even on your smartphone. So you can sit anywhere in the world and access the report of your lab. So this artificial intelligence driven analysis will give you cell morphology, WBC, RBC platelets, and 7-part differential counts, which includes blasts and NRBCs. Now we have recently come up with Shrava in AI100. So Shrava uses a microfluidic cartridge for urine microscopy. So I'll just show you how the microfluidic cartridge looks like. So this is what the slide looks like. It has three places for samples. We have to load 100 microliter of sample in each. You need not centrifuge the urine sample. You have to load it on the slide and let it rest for 5 minutes. After sedimentation, 5 minutes of sedimentation time. Once that is done, the slide is scanned into the device, and the device, using its AI or the algorithm that it has developed with Shrava, it scans the entire slide and gives us pre-classification of 7 classes, that is crystals, cast, yeast, RBC, bacteria, epithelial, and pus cells. There's another feature of this device which is very interesting, and that is evidence-based reports. So when I'll show you this video, so when the slide is scanned and analyzed and you are seeing it on this platform which is called Mandara, you can click on every category, all the WBC cells that it has categorized, and see the evidence of the cells, what it has tagged as IG, what it has tagged as blasts, and you need not agree to its predictions. If you think it is wrong, it can be reclassified. It is just suggesting to you. So the decision is solely in your hand. So we have different categories, WBC, where it gives WBC morphology, RBC, where it gives RBC size and poikilocytes, and along with visual evidence. If it is saying I've seen 439 round macrocytes, it's showing you the cells it has picked up from the smear. Similarly, poikilocytes, we give ellipto, ovalo, target, teardrops. Again, for every prediction it makes, there is an evidence. So there is no, you don't have to agree to it blindly. You can make your decisions by seeing whatever evidence, whatever cells it has picked up. You can agree or disagree. Then there's another feature of this software, which is We know that we have been trained throughout our lives on the manual microscope. So we are very comfortable with that view. So, with that point in mind, they developed a FOV view, which gives you a manual microscopy like appearance. So you can see that, see, if you see on your right side, it is showing you all the places where it had taken pictures. And you can click on every circle here and see which FOV has been analyzed. It also tells you whether this particular FOV extracted how many cells. So everything on this solution is evidence based. So how do we say that we are better, or AI100 is better than the other players in the market? So most important is that it is a robust, it is the AI that we have developed is very robust because it is stain agnostic and smearing agnostic. So any kind of manual or automated staining and smearing, both kinds of slides can be used. It also has higher throughput, around 20 slides per hour can be used. So that enables you to provide faster TAT, and there's lower cost per test. Then we have 400x magnification. You can work from anywhere. That is by default. This is how it works. So this machine you can install in some village in Rajasthan, and you can sit and report in Karnataka. There won't be any issue at all. So that is enabling telepathology. Also, there is remote upgrade. So every time we sitting in the office in Bangalore, when we improvise the software, due to its cloud-based approach, we can upgrade the software right from there. We need not ask a technician or an electric or a engineer to move to your location and upgrade the device. Also, we have full view of a field of view report. This is good because what we have seen is that digital microscopy is a way of working in lab, and not most of us are comfortable with it. So this particular feature helps you to seamlessly shift to digital pathology. Then all the features are there in this particular machine by itself. Right now we are having, we used to have shown it till now. Now we have also started offering solution for Shrava. So for smaller setups, it is economical since one device is going to give you larger solutions. So this is the team this is a leadership team who has been pivotal in bringing this product in the market. And this whole team is supported by 50 other tech teammates, which consists of, so it's an interdisciplinary work. It's not a entirely technical work. So we have teams of data scientists, software engineers, robotic engineers, microfluidic engineers, medical doctors, and product managers. So all these people work together, and that is how this product has been launched in the market. So with this, I conclude my talk on introduction of AI100. And now I'm going to call upon Dr. Gautam Bhagwat. He's a known name in pathology. He's one of the early associates with SigTuple. He used digital pathology quite seamlessly, and he has done extensive work on our device AI100. He's presently working as a consultant hematopathologist and assistant professor at R.D. Gardi Medical College, Ujjain. His areas of interest are hemato-oncology and flow cytometry. He has done a fellowship in laboratory hematology and from the prestigious Tata Medical Center, Kolkata. He worked as section in charge in Suraksha Diagnostic in hematology and flow cytometry. He has had many accolades to his name with training in University of Salamanca, Spain in flow cytometry, and he's also received a travel fellow award at the annual conference of the ISLH in Vancouver, Canada. So I hand over to you, sir, the dice.
Thank you very much for that kind introduction, Richard. And thank you, SigTuple, for giving me this opportunity to present what we did, what I did when I was there. And I got a lot of support. I made a lot of friends in SigTuple at that time. And we did extensive validation kind of a thing with SigTuple and Shonit, along with a few changes in Mandara that were made at that time, which improved the software, I guess. So I'll just go through the journey of why digital microscopy is important to me in my perspective, and the other thing is what we exactly did at Suraksha Diagnostic Center, where we had this SigTuple and AI100 kept with us for validation, because I was fortunate enough to have another digital microscope with me, digital morphology analyzer. So we kind of compared the results, and we did a lot of validation with this. So uh, so what exactly is the role of a pathologist or a hematologist? It is reporting, yes. But other than that, as now I am an assistant professor, I am also teaching. Being a hematopathologist, I regularly get slides for reviewing and consultation, and most of it at this moment of time is WhatsApp images. Also, I need to make presentations like these and put my pictures in various publications. So apart from reporting, these are certain areas where this digital things, digital microscope is really very useful. And but at the end, it is reporting that we pathologists do, and the reporting should be timely, accurate, and cost effective. So whenever I release my report, the concern is who is actually using my report, who is my end user. If it is a referring doctor, I am happy because he understands quite a lot of what I have written in it, what exactly the values mean. But nowadays the problem is the end user becomes the patient or the patient's relative, and that is a kind of worry to me. Why? Because they ask unnecessary questions, they shout, they become depressed after looking into the reports. They go on to Google and just imagine, I just put, can your platelet count fluctuate? I could not even complete the fluctuate spelling, and what I get in the drop box is, can platelet count be wrong? So Google gives this idea, the patient clicks on that and then say that you are giving my platelet counts wrong. Then what happens is, we all of us know. And what we do is we go on strikes, we have this indemnity insurance. I hope we don't see this day when the clinics would have all these guards kept to protect us. And also, I hope we don't end up putting a surcharge if you insist on annoying the doctor with any self-diagnosis you found on Google. So the point that I want to make is, nowadays the patient and the relatives are so aware, they come back to you, ask for whether my report is correct or not. We did in the other lab, it was something else. So you need an evidence for what you have reported, and that is what the theme would be, to have a visual evidence, to keep it as a evidence for getting confidence while reporting. So the way forward is automation. The automation should be precise, reproducible, and would give a better tat. But the problems are whether it is economical or not, how are the after sales services, and the biggest thing is acceptance. So people do not accept. Even myself, I could not shift to digital microscopy immediately from the manual microscope. Each time digital microscope gave me something, I would confirm it under the microscope, because the initial 6 months are like, it is hard to accept that it is seeing the entire slide, it is giving you accurate results. The other thing is, skilled manpower is getting lesser and lesser. My father is also pathologist, and he would always tell me, "Hamare time, in our days, we would have those technicians who can do anything, who would do anything." But now it is getting a bit tough. So automation definitely is the way forward. And now you must have seen clinical biochemistry and molecular diagnostics have been completely automated. But the other fields such as clinical pathology, which includes the urine examination, hematopathology, histopathology, clinical microbiology, still the entire automation has not come in. And the biggest, I should not say hindrance, but the biggest uh, reason why the entire automation is not possible is because all these four uses this instrument, that is the microscope, and a person or a doctor looks into the microscope to give out the final report. This is normal workflow. You get the sample, you put it in your machine, you get some counts, and if the counts are everything is normal or within normal ranges, you authorize the report. You get everything through your LIS, and if there are flags raised, you would prepare a smear and look it into the microscope. So this is the normal workflow in any hematology lab, or for that matter of fact any lab. So what do the analyzers give me? They give me the counts, the hemoglobin, the WBC count, platelet counts, the indices, the differential count. But I require slides. So everybody knows a slide review is very important in many samples. And this slide would give me the RBC shapes, the platelet estimates, the causes for pseudothrombocytopenia, hemoparasites, the manual differential counts where you have flags or the WBC abnormalities such as identifying blasts and etc. So slide is a important, even though nowadays analyzers have become come in great deal and have reduced the smear making to almost nearly 15 to 20%. And if you are in a regular lab where you are not seeing many hematopathology samples, it would come down to 5 to 10% with good validation. Still, there are slide review criteria given by ICSH, and we follow these criteria in most of our labs. Depending on the situation, what kind of hospital or what kind of lab you are, you need to make certain changes, but those all should be validated. Now, as Dr. Richa has already told, there are certain limitations to my manual smear review, and all of us have experienced this that these are laborious, these are strenuous, they require a lot of time, they require lots and lots of training. There are no archives, no traceability, and requires storage space. Now, disclaimer: reviewing smear has no alternative, so you have to review a smear. But reviewing a manual smear has answers, and the answer is digitalization. Automation in smear review saves your time. It spares more time to review cases that are really important. There are less chances of inter-observer variability. You have a remote access, so you can have opinion of any person, or you can view your cells even in the midnight at the comfort of being at your home, so-called work from home. uh, the 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 reports that you are putting out are traceable within visual evidence. You can use it as an teaching tool. In fact, I have started doing this. I put out a picture to my all postgraduate students, one cell or two cells or a field of view to my postgraduate, and I asked them to classify the cells. Has come up a big way in competency assessment. CAP sends us these digital pictures for competency assessment. And second, an expert opinion from any hematopathologist sitting anywhere in the world can be you can get that. So the answer to manual smear review limitations is the digitalization. And therefore now we are shifting from this microscope to this microscope, which is not only a microscope, it is also a artificial intelligence based platform which is giving you out your differentials. So at Suraksha Diagnostic, we did lots and lots of validation. For example, this is one case where we stained two slides for the same case, and both the slides were scanned in Shonit AI 100 twice a day for 20 continuous days. And then we compared the values. The SD, if you would see, almost nearly less than 3% in all the cell types. So in that ways the reproducibility was ultimate. It was very nice, it was very acceptable. Another case, a case of acute leukemia with 85% blast on manual smear. We scanned this slide 5 times in a day for 5 days just to check how much variation would I get if uh, we process the slide on different times of the day, and whether that is affecting anything. But because it, it might be so that because it involves optics and it involves many things, there might be differences. But again, if you can see, all the SD percentages are less than 3%. So again, excellent uh, this reproducibility of the results. This was the case with the blast. In one of the runs it showed 86% blast, and beautiful blast, there is no issue. We can see this. And the most important thing is you are seeing all the blasts in one frame. So in a manual microscope, what happens is you have to search for blasts. Now here what is happening, all the blasts are in one frame in front of me. Even if I feel something is not a blast, I can pull it out and put it in another category. But the morphology of all the blasts at one go, so the description also becomes very easier. So we compared our result with the another digital microscope or digital morphology analyzer that was kept in Suraksha Diagnostic, and this was the pre-classification data. I have pulled out this data on initial 50-60 samples, and as you can see, everything was within the range. Nothing went out of the limits, and so there was an excellent correlation. Definitely this is the pre-classification and data, and that is more important in terms of classification, because the more accurate the pre-classification data is, the lesser time would go to reclassify it. Again, there always has to be a man behind the machine, so you cannot go away without reclassifying it. But what I would wish is the digital morphology analyzer would give me an accurate pre-classification data, so that my job becomes easier and I can spare my time more on cases which really require my inputs on that. So this again had a good correlation with existing morphology analyzer in the market. This is a case again. This will be discussed later, but I just wanted to go ahead with the flow. So I have put this case. The analyzer finding showing a 24% large unstained cells, and SigTuple AI 100 flagged 54% blast, which was backed by visual evidence. Not going into detail, but again, this gives you confidence. You have this slide always with you. So this is a case sometimes from 2021 down the line 2 years. I have this case. I'm going to have this case for so many years ahead, because everything is on cloud. So even if my computer corrupts, I still have this on my cloud kept. So I can always go back. I can always see what is in what case, which type of blasts are there, etc. Yeah, another thing. So somebody sent me across these images. So the pathologist around listening to this talk will immediately know this is a spotter, this is an emergency, and you need to urgently communicate to do a fish for PML RARA. But this is important because the younger pathologists who are just passed out, you miss on these cases because the counts are not very high. But if the morphology analyzer gives me this with its artificial intelligence, places into blast or promyelocyte, the postgraduate student or the fresh pass out would immediately send this across for my opinion, and I can give my opinion from anywhere, wherever I am sitting. So it becomes very easy. And definitely these analyzers give you better picture than what we are clicking using the mobile phones and sending it across on WhatsApp, because the image quality deteriorates a lot and it is tough to look into the nuclear details. So mainly it is, mainly as I feel it important, it is for WBC classification, but still RBC again is important. And why is it important is because uh, RBC there are so many things to see, but we need to grade it. Now, why grading is important is because you need to communicate to the clinician what exactly you are seeing. Now, I've seen people writing mild microcytic or microcyte plus 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 plus. I have seen such reports. Now that doesn't make sense, because what is this plus 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 plus? Nobody knows. And for that, ICSH has given these guidelines, and rather these are recommendations, and the recommendation says there is nothing like 1 plus for any of the poikilocyte except for schistocytes. There is nothing like 1 plus. And most of the cells, if you can see, those are the macrocytes or microcytes or hypochromic cells. Less than 10% again is nothing. So it is assumed that 10% microcytes can be seen in any normal person. So only if it is more than 11%, you have to grade it, you have to write it moderate or many, depending on how many they are. But the catch here is all this has to be done on 1000 RBCs, and I'm sure nobody on a manual microscope is going to scan 1000 RBCs, derive a percentage for microcytes, and then say what grade of microcyte it is. But and is this important? Yes, it is important, because if you see poikilocytes, acanthocytes, we relate it to alcoholic liver disease, but it is only alcoholic liver disease if it is 3 plus. You can have acanthocyte 1 plus and 2 plus in other cases also. Or for the same way, the schistocytes 1 plus, important to just to tell that there are certain schistocytes, because um, in many graft rejections or such conditions or cancer chemotherapy, those are important uh, clues to tell that something wrong is going on. So this is what Shonit will give you, and it will give you the percentages, the actual percentages. And if you can see, this is from more than 1000 cells that the percentages are given. and I can accordingly grade my microsites or other poikilocytes. And therefore this is a very good tool to put your RBC morphology in your peripheral smear report. A case of autoimmune hemolytic anemia, failed steroids, rituximab was started. His hemoglobin was 6.8 DCT positive. Now, the WBC count was 69,630 on counter, and the platelet count was 5,70,000. What my counter shows me a huge population in this extremely left area, and I know this left area is for nucleated RBC. So, whenever you have this thing, you need to count the nucleated RBC per 100 cells. Now, if you see what Shonit gave me was 171 nucleated RBCs per 100 cells or 103 WBC. Now, again, practically, this is not possible that you count so many cells, and even if you put in, you start counting, you spend lots and lots of time on doing that. So you have visual evidence of nucleated RBC. You get your nucleated RBC number. You immediately give a corrected WBC count, which makes our job very easier. Platelets, again, EDTS sample for routine checkup, decrease platelet count. And what this software gives me, it shows beautiful clumps, which if it would have been a manual microscope, I would have to go through the entire slide to find such clumps, but it has detected it and given me the number of clumps that are present. So I can say that this was a pseudo thrombocytopenia. I can ask for a citrate sample, or I can just say platelet clumps present. It seems that the platelet count is adequate. Another case of thrombocytopenia, uh, less than 1 lakh for last 10 days. Actually, this patient who had to undergo chemotherapy, and as a protocol, less than 1 lakh chemotherapy was not being given. He was roaming around places, and he landed up with me. So when I saw this on the digital microscope, there was uh, not only this platelet satellitism that you can see the platelets around the neutrophil, there was also platelet phagocytosis by the monocytes, and that is what we reported as a pseudothrombocytopenia, and again told the clinician that the platelet looks adequate on smear because there is this platelet satellitism and platelet phagocytosis, mostly probably induced by the previous chemotherapies that the patient has got. So he can go ahead with chemotherapy. So this helps a lot. Again, I was being a hematologist. Most of my time goes on hematology, but we all know these beautiful crystals when we see these in our urine microscopy. As PG first years, we get really excited and we go on commenting about it. But nowadays, what has happened is there are many people who rely on senior technicians for urine reporting, and again, as I said earlier, skilled manpower is it is hard to find skilled technologists, and they might miss on casts and crystals in your slide, or they might feel it is unimportant to report. uh, so in such situations, when you have this visual evidence with the Shrava application at AI 100, this helps a lot. So any peripheral labs, remote labs, you can always put this urine slide in this, and you can see for your from your own eyes, sitting remotely, what to report. So finally, the workflow of my lab, as I had told, it starts with the sample, and if slide is required, it ends up on the manual microscopy. But now I guess this will largely be replaced by the digital morphology analyzer, the AI 100. And as I have tried to emphasize the importance of this in these few slides, I hope people listening would shift to largely shift to digital microscopy, and manual microscopy role would be lesser. Although being a proud morphologist, I will never give up my microscope, but yes, the role would be reduced. So the take home message from for digital microscopy is the reports are standardized. There is image incorporation in the report. You can increase efficiency. You can trace the images. You can have a cellular digital history of patient. You have improved review or opinion at global level, and you have improved tact. This is RD Gardi Medical College, where I am at present assistant professor, and Tata Medical Center, Kolkata, from where I did my fellowship in hematopathology. And this is Suraksha Diagnostic, where I have experienced everything about digital morphology, and which I think I could highlight in today's talk. Thank you very much. Thank you once again, SigTuple, for giving me this opportunity. Thanks a lot.
Thank you, sir. Thank you so much for this enlightening talk. Um, actually it's a privilege to know that you have used this device so extensively, and you can actually delineate for the audience here how it has been so useful for you. If the audience has any questions, please put it on the chat box. We'll take it at the end of the session. Now we'll move to the next talk, which is utility of AI 100 in malaria. So what is AI 100? It's a digital morphology analyzer. And what are digital morphology analyzers? So they are not a thing of recent. They have been here since a very long time. Since the first digital morphology analyzer was made in 1966 by the company, which called it SIDAC scanning microscope system. So remember, this is the time when we used to do differential count, or rather our uh, fathers used to do differential count on by manual procedures. So as soon as the advent of computers began, people, the technologists of that time, they started integrating digital imaging system in hematology. As a result of that, we got our first digital morphology analyzer, SIDAC scanning microscope system. Closer to that, another company came in, Corning Lark, which used to give 5-part WBC differential count on spun smears of blood. So now we need to remember that at that time, uh, the digital imaging system, that technology was not very refined. Yet, this definitely stirred some classes of pathologists and technicians who wanted to test if this is valid for that time. So I have a proof for that, because these are two papers, two scientific publications which I could lay my hands on. One is from USA and the other is from France, which has been translated to English for us to understand. So they actually tried to validate these DMAs so that they can prove that the DMAs perform better than the traditional manual method that the people used to follow at that time. However, two things happened. One was that the digital imaging system was not as refined of 1900, 1960s. And the other thing is that automated analyzers, that is the flow cytometry based analyzers, it entered the hematology markets by 1980s. And we all know that that has been a game changer. So we forgot about DMAs. And then came COVID, and we wanted to look for digital pathology solutions. And that brought back the spotlight to digital morphology analyzers. So, what is digital morphology analyzer? It is basically a smart microscope. It's a digital microscope integrated with sophisticated algorithms, which will interpret images. So now the technology needs to be relevant to the time. It was not relevant in 1960s. But now the digital imaging, the algorithms, everything is improved. The computers have phenomenally changed. The face has changed, the technology has changed. So DMAs are more acceptable now. Also, every technology has to have relevance to social needs. So uh, hence we started developing a malaria module in our device. Now we know that malaria is a global health problem. And according to World Malaria Report 2022, the bulk of the problem of malaria lies in these 11 countries, which WHO calls as high burden to high impact countries. Unfortunately, India finds its place in these 11 countries. We not only contribute a good amount of cases, but we also contribute a good amount of death toll attributed to malaria. So in 2021, 168 million cases were diagnosed of malaria, out of which 428,000 people died due to malaria. So what has WHO done to eliminate malaria? Its strategies is based on these three pillars: vector control, rapid and accurate diagnosis, where our role comes in, the pathologist roles, and the availability of rapidly acting effective drugs. So, how do we diagnose malaria? So, WHO has recommended that before we start any anti-malarial treatment, a prompt parasite-based diagnosis has to be made either on manual microscopy or by rapid diagnostic tests. Microscopy requires both thick and thin smear. What are the different methods of malaria? I'm sure the audience knows. I'll just do a quick recapitulation here. Manual microscopy, this is the age-old method. It has started since the time the parasite was discovered in 1881. And then in 1995 came rapid diagnostic tests. They kind of revolutionized the entire diagnostic system in malaria. So how do they function? They detect circulating parasite antigens, which are basically two important antigens, histidine-rich protein 2 and 3, and parasite-derived LDH. So using these antigens, we pick up malaria in the patient blood sample. They were so easy to use and so popular that WHO has given a data of 270 million RDTs used annually all over the world. There are other methods as well, like molecular methods, but they are not as commonly used as these methods are. Now, coming to manual microscopy, it's the most commonly used method. We all have used this method. What it requires is a very basic lab facility, a good quality GMSA stain, and microscope of sufficient quality. But a very key elemental thing to this method is the expert human eye. An eye that can identify, that can grade, that can also typify which kind of parasite it is, and also quantify the level of infection in that blood smear. Also, it should be able to ascertain the life stage of the parasite. So, what I'm trying to say is that it's an error-prone process and it requires substantial human input. And how can we have an optimal human input? Only by extensive experience, constant training, and education. So, with training, patience, and competence comes an excellently used manual microscopy method. But that is not the case in the real world. There is variability, and there is variability across person to person and also over time and geography. So what are the challenges malaria diagnosis right now? Like I said, that the quality of microscopic based diagnosis is inadequate. I'm not just talking about the man behind the microscope, that I've spoken enough. Even the quality of smearing and staining is variable across different labs, different cities, different countries, and also the quality of microscopes that we use. So in all, there's a lack of standardization, the lack of constant quality control, and that leads to inadequate quality of microscopy based diagnosis. Ironically, in countries with low endemicity, rapidly diagnostic test kits are not commonly used. Rather, we use manual microscopy method. So it's a weird cycle because low endemicity areas will find microscopists having very limited cases all through the year. So the experience is less routinely, and this adversely affects malaria control and elimination. Now, this is microscopy. What has happened with rapid diagnostic tests? So there was a paper published from Peru which said that there was an index case where the patient was RDT negative, that is rapid diagnostic test negative, but by manual microscopy, he was found to be positive for malaria. So they wondered why is it so? Because in those countries, RDTs worked beautifully till then. So when they analyzed that patient's sample, they realized that this particular parasite had mutated and had stopped expressing HRP. So this is the new challenge that we are facing. These RDTs are resistant in those cases where the parasite is mutated and it no longer expresses the antigen on which we were banking on to detect the infection. So, realizing the magnitude of the problem, WHO has said that we should be harnessing innovation to reduce the malaria disease burden, which means that now they are coming up with, they want the technologists, the people around them to come up with solutions which are digital solutions, which involve data analytics, basically any solution that can help them to reduce the burden of the disease. So digital pathology with AI can be a great tool in this, following this approach. And automated microscopy is a promising development for malaria diagnosis. How is it promising? Because the artificial intelligence can help us to identify infected red blood cells. So this problem has been lurking for a very, very long time. So people, depending on which era of technology they were in, they started trying to bring out solutions in their own way. So I've enlisted certain papers here just to communicate how technology of that time is used relevantly. So in 2006, this paper was published, The Remote Diagnosis of Malaria Using Telemedicine or Email. So there, at that time, email was prevalent. That was the commonly used technology. So they have published a paper in USA, and they used to ask the people in Indonesia and Thailand to send the pictures of the blood smear, and the experts sitting in USA would tell whether that's a malaria parasite or not. So they tried the best using the technology of that time. So they've used telemedicine, email, and there was another paper in 2009 that started using digital image analysis. Both on thick smears and thin smears, extensive research has been done to develop devices on these. Then computer vision based technologies were used. This is an Indian paper with Indian scientists working on it. Then sequential classification system for recognition of malaria infection. So why I'm talking about all these things? Where do we come? What is the role of pathologist here? So role of pathologist is a very significant one in development of AI. So this computational pathology team, or this team which that develops artificial intelligence, is not a single team. It's a multidisciplinary team. The pathologist, he delineates or highlights the clinically relevant issue for the rest of the team who are going to develop AI. So we have pathologists, we have a data scientist who is going to develop and train the algorithm, and an engineer who is going to provide us with an operating environment. Now, after this AI has been developed, it will go to the actual clinical practice, and the pathologist sitting there is going to play a pivotal role in applying, monitoring, and relaying a feedback to the developing team to optimize the solution. So we also have as important part in development of AI as the other components of this team have. So how does malaria module work in our system? So we have a combination of multiple deep learning models. Deep learning models are nothing but AI, machine learning models. And the most important step that is required in developing any algorithm or any AI is data preparation. So data preparation means we have to mine slides. For us, what they call data is slides for us. So we have to mine slides across all stain types, across all infection type, that is P. vivax, P. falciparum, across all stages of the life cycle. And also, we need to take it from different geographical areas, because that is going to give a robust representation of how malaria looks like across, and the device becomes relevant to every center on the earth. So this kind of data collection makes the device or the AI very robust. So this is the most critical step in development of any AI. After this is all back-end things that happen, but I just want to give you an overview, and I've oversimplified it. This that how this AI is developed. It's not a fluke. It's properly thought, meticulated, decided, and then multiple experiments are done to refine this technique. So we have the first detection model, which is going to, this is a deep learning model. It is going to pick up malarial parasites, which it thinks those patches that these are malaria. Then it goes to another model, which is the classification model, which is going to filter out all the false positives from this. And then all this data goes into ensemble model, which specifically tunes to remove any non-malaria patches. So after all this is done, the model is trained, tested, and then we have an optimized model ready from our end. And then it is given given to the end user. So when you scan your slide, and after AI has done all this, run it through multiple models, then what you get is an output. That output is that this said sample detected parasite or not detected parasite, along with a quantification or confidence score, where it says that yes, this sample has no suspects at all, strong suspects, or suspects. So I'll explain it to you how it is seen to the user. So this is our using platform Mandara. And here, like Dr. Gautam has already shown you, that we have different windows describing details of each. There is a malaria window as well. So here, if you click onto this window, you will see that the model has flagged that this particular sample has malaria, is detection of malaria in this case, and it has counted the number of parasites it has detected, 192, along with visual evidence. So all these boxes with parasite infected RBC, that is called patches. So I'll show you a closer view. This is the strong suspect, the patches. If I click on one of these patches, it takes me to the FOV view. So while it picked that one slide and said, oh, this is a parasite, it is now taking you to that entire patch where you can see that yes, it has taken this parasite from. So there's a comparison that you can make. You can also use this FOV view as an opportunity to see if the AI has missed any other positive parasite or not. The good thing to note here is that there are a lot of stain marks here, but the AI has ignored all of them. There are a lot of artifacts also. It just picked the right accurate one. So this shows that the algorithm is really robust and accurate. This is another example of P. falciparum. This particular sample had falciparum gametes, and the model detected 20 of them with visual evidence. I can click on any of these patches, and it is going to take me to the FOV view. So we have a malaria case which we'll be describing in detail by Dr. Pavitra. So to summarize, automated digital microscopy in malaria is a very, very promising tool. It will enable healthcare providers in remote areas to provide expert malaria diagnosis. It can support training. It can become reference standard. It will also circumvent logistic challenges, especially in areas where RDTs are not, rapidly diagnostic tests are not easily available. It will also improve turnaround time. And automated digital microscopy gives you a provision of telepathology. So you can bridge the gap where the expert is needed, but he is not present, and the gap and where the expert is present, but he can't be, he can't provide his services there. So telepathology is going to bridge that gap. Also, it adds value to the all lab functioning of that particular center that is present in remote centers or in areas where experts are not available. So, do we need to automate digital microscopy for malaria? I think I have established the use case. Yes, we should be doing that. So will it reduce the error? These are the only criteria we think of, and we think that whether we need the automation or not for this particular use case. So we need an automation. It is also going to reduce the errors that happen in diagnosis. And overall, it's just a tool. It is not making decisions for you. If you do not agree with the predictions, you can always say no and give it as a negative report. So rest be assured that AI is not making decisions for you. It is only and only adding values. So to conclude, this is my team. This is the medical team that works at SigTuple. We are 6 doctors, and along with giving that kind of support that I just enumerated, we also try to evoke interest in our peers by poster presentations, by giving small talks, or kind of contributing into conferences. And we hope that this webinar series is going to do the same that we have been doing for last so many years. So with this, I conclude my talk, and all the questions are welcomed on the chat. Now I would like to call upon Dr. Chaitra, who will be discussing certain interesting cases that we have had in last so many years. And over to you, Chaitra, now.
Yeah, hi. Good evening, all. That was a very informative talk, Dr. Richa. Can you see my screen?
Yes.
Yes.
Yeah, hi. Today I'll be discussing a few cases, that is hematological malignancies, which was reported on SigTuple's AI100. So in the medical field, as we all know, pathologists play a very crucial role in providing the right diagnosis. And artificial intelligence is a smart solution that the pathologists can reliably use in the routine day-to-day practice. So coming to the case 1, so we had a 62-year-old female patient who came to an emergency department in the late evening to a tertiary care center. So the patient came with the symptoms of fever and fatigue. On examination, patient had pallor. So the routine investigations were ordered, and the CBC revealed a hemoglobin of 7 gram per deciliter, and WBC count was 20,000, and platelet count was 13,000. So a peripheral blood smear was prepared and was scanned in our SigTuple's AI100, and the images were captured. So the AI-enabled software identified all the cells, and it categorized the WBCs, the RBCs, and the platelets. So in AI100, we have the microscopic view and the patch view, as you all saw. So this microscopic view is very similar to the manual microscopy. So we all as a pathologist have a phobia of missing our microscopes. So, but with this additional feature, we would perhaps not miss our microscopes. So in this microscopic view, we could see an RBC picture of microcytic hyperchromic blood picture, and WBCs have increased. Where gives an accurate differential count with the visual evidence. In this case, there was neutropenia, and there was around 39% blast. So this is a patch view, which I was talking about. So here we can make out the blast, which was of high NC ratio, fine chromatin, and an inconspicuous nucleoli. And few blasts showed ore rods, which was really virtually evident, similar to the manual microscope. So all the morphological features, including ore rods, are similar, are well appreciated like our manual microscopy. So we also have a feature of platelet count, which is similar to the manual microscopy, wherein we count platelets in 10 fields and take an average, and this gives a total platelet count. And we can multiply this with the 15,000 count, or 15,000 or 20,000, as we do in our routine practice. So this gives the platelet count. So in this case, there was thrombocytopenia. So with the leukocytosis and 39% of blasts with virtual evidence of ore rods and thrombocytopenia, so any guesses with the diagnosis? So we gave a diagnosis of acute myeloid leukemia. So as I initially told, in this case, the patient came in the late evening where the pathologist was really not available. So using of AI100, it actually averts the presence of the pathologist in the lab 24/7, and it helps the pathologist to give a quick preliminary report to the clinician, and also helps in recommending the further molecular testing. So coming to the second case, so we had a 40-year-old male patient who came to a primary health center in a tribal village where there was no access to the pathologist. So the patient came with the complaints of fever and abdominal pain, and the patient had splenomegaly. So the only test available there was a CBC. So there, the hemoglobin was 7.5 gram per deciliter, and the WBC was around 45,000, and the platelet count was 9 lakh. So as Dr. Richa pointed out, the AI-enabled software, so it gives the remote review. So in this microscopic view, we could see neutrophilia with mild shift to left. So the AI-enabled software here, including the blast count and the NRBCs along with the IGs. So here we could see neutrophilia along with shift to left. Here we can make out the metamyelocytes and the myelocytes and the promyelocytes. So here we also had monocytosis with the visual evidence and basophilia. So as a beginner, it's very difficult to identify the basophils. So, but our AI100 picks up the basophil with a high accuracy. So here there was thrombocytosis. So as I said, this case was, there was no pathologist for access. So this case was reported by a hematopathologist in Chennai with the help of the remote access. So we also have an additional feature wherein we can put in our peripheral smear impression and give out a report to the patient. So in this case, the cloud-based software enabled the remote reporting. So with the help of an internet connection, a laptop or an iPad or even the mobile phone, we can review the case and approve the case. So which helps in reducing the turnaround time and helps the critical patients to get the treatment on time. So the third case was a 68-year-old male patient who came to the medical OPD with a complaint of weight loss. On examination, patient had hepatosplenomegaly. So the CBC revealed 6.8 gram per deciliter and WBC was 54,000 and with the platelet count was normal. So the AI100 gave the AI-enabled software gave an accurate differential count with the visual evidence that it shows 94% of lymphocytes. And the microscopic view showed increased in leukocytes with increased lymphocytes. And we could also appreciate the smudge cells or the basket cells. And the platelet count was normal in this case. So this is pretty a straightforward case. So this was a CLL. So AI-powered analysis, it ensures high sensitivity and specificity of the results. So, and it can be used for a routine reporting. So I'd like to end this with saying a few words on it. Artificial intelligence would be a perfect companion for the pathologist, and it gives 100% prospective quality assurance. Thank you. So now I would like to invite Dr. Pavitra to discuss about a few cases. Over to you, Pavitra.
Yeah, thanks, Dr. Chaitra. Can you stop sharing your screen, Chaitra?
Yeah, I stopped.
A very good evening to all the participants here. I'm sure it's been a feast for you, for those who are interested in digital pathology. So, and my previous speakers have done an excellent job. So without much delay, let's get started with the next cases. So this is case number 4. This was a 26-year-old gentleman who visited a healthcare center with complaints of on and off fatigue and persistent low hemoglobin. And he had received prior iron therapy, but he was not responding to treatment. On examination, he had pallor, but no icterus or hepatosplenomegaly. And the CBC was ordered. Hemoglobin was 10.6 grams per deciliter. Hematocrit was 34%. RBC count was 5.8 million. MCV was 70 femtoliter. MCH 22. MCHC 26. And REW was 16.1. And WBC and platelets were within normal limits. Serum iron levels were done, and it was 150 micrograms per deciliter, which is normal for this age. And ferritin is 290 nanograms per ml. So the range for serum iron levels is between 15 to 150, and ferritin levels 15 to 300 or 350 nanograms per ml. So it was essentially normal, but still looking at the CBC, you can make out he had a microcytic hypochromic picture. So the peripheral blood smear was analyzed on SigTuple's AI100. So by now, I think you people would have been familiarized with this digital platform. So I need not go into the details. So these are on the right-hand side, what you see are the FOVs. When you click on each of the FOVs, it'll bring out an image, which is equivalent to your 40x view on your manual microscope. And here on the left-hand side, you can see the differential in that FOV. So as you can see, it looks more like a microcytic hypochromic picture. And when you zoom in, you can see that there are microcytic hypochromic cells, there are elliptocytes, polychromatophils, target cells. So there was a bit of anisopoikilocytosis with microcytic hypochromic picture. This is what Dr. Bhagwat very explicitly described regarding the grading of RBCs, which is a very good feature in AI100. It grades your RBCs. So this is showing you a grading of 3+ when it comes to microcytes, and 56% of the RBCs were microcytes. And the other ovulocytes had been picked up. These are the target cells which were flagged. And these are the NRBCs, amounting to nearly 3%. So with all these features, what would be the diagnosis? It's a young adult male who comes with a persistent low hemoglobin, and he has a microcytic hypochromic blood picture. He has received iron therapy, but he's not responding to it. So what would you think of? Any takers? So we can think of all these differentials. Firstly, the disorders of iron metabolism, under which you get iron deficiency anemia and anemia of chronic disease. Iron deficiency anemia is ruled out because his serum iron levels were normal and he's not responding to it. And the next possibility of anemia of chronic disease is also unlikely because he didn't complain of any chronic illness. And usually in ACDs, it is normocytic normochromic anemia to start with. And in the later stages, hypochromasia and microcytosis will set in. Coming to the next group of disorders, which comes under our differential, is disorders of globin synthesis. That could be thalassemia minor, because major wouldn't present like this. It would be a more aggressive and a more hemolytic kind of a picture. So we're thinking of minor thalassemia minors in this case. So a useful pointer would be to calculate the Menzel's index, which is MCV divided by RBC count. If it is more than 13, then it favors IDA. And if it is less than 13, it is more in favor of thalassemia. So in this case, it was 13. And then next differential would be a sideroblastic anemia. But in this case, it will be either increased iron stores, the ferritin levels will be increased, and you could see sideroblasts. You can see sideroblasts on bone marrow examination. This was also unlikely. So ruling out the possibilities from the differential, we are left with this disorders of globin synthesis. But what do we do next to come to a diagnosis? So hemoglobin electrophoresis was ordered, which was essentially normal in this case, with a hemoglobin hemoglobin A of 97%, A2 2.5%, and fetal hemoglobin 0.5%. Hence, excuse me. Taking a hematopathologist's opinion, genetic testing was ordered, and on DNA analysis, 2 alpha genes were deleted. That was the report. So, sorry. So when it comes to normal hemoglobin, we have 4 alpha genes and 2 beta genes. So if because there were deletion of 2 genes, a diagnosis of alpha thalassemia trait was considered. So as you all know, thalassemia is a heterogeneous group of disorders with decreased or absent synthesis of globin genes. It's a quantitative defect of globin chains, and we have 2 types, alpha and beta thalassemias. So let's move on to the next case number 5. A 36-year-old gentleman visited a clinic with complaints of fever, chills, headache, and myalgia from past 3 to 4 days. On examination, he was febrile and he was pale, and he had mild splenomegaly. The CBC was ordered. Hemoglobin was 11.6 grams. Hematocrit was 36%. and all other RBC indices were normal. He had neutrophilia and moderate thrombocytopenia. His urine analysis was normal. Excuse me, sorry. And his typhoid and dengue tests were negative. The peripheral blood smear was analyzed on AI100. So what do we see here? There was grade 2 to grade 3 grading has been given for many of the poikilocytes, and the fragmented RBCs, as you can see, have been captured. And the WBC differential showed 82% neutrophils, which corroborated with the CBC analyzer report. And the platelets, the average of the 10 fields is given as 6.3. When you multiply by 15, it gives you a 90,000 platelet count, which is again corroborating with your CBC findings. Along with that, the additional feature here we have in AI100 is it picks up the Jane platelets and also the platelet clumps, as shown by Dr. Bhagwat. So here there were Jane platelets in this case too, which have been shown here. The most important feature which was flagged off is the malaria parasite with a count of 1031. This is the count of predictions, which will put it into a strongly suspect category. Excuse me. As you all can see, there are many malaria parasite in different stages of its life cycle are seen, with many amoeboid trophozoites, some schizons, ring forms. Here again, you can see some trophozoites, schizons and ring forms, and the gametocytes of falciparum are also seen. These more pictures of the same, the compact trophozoites. So this time the diagnosis is already ready in front of you. So what's the diagnosis? It's mixed infection. Plasmodium vivax and falciparum were seen. So how the AI identifies the parasites and flags it. So this is the 40x FOV. Excuse me. Whenever you this AI comes along with a prediction of parasite, it flags it off and marks it with a square. And when you have any doubt, you can zoom in. We have up to 350x magnification, digital magnification feature, which is available, which will take you to this view where you can take a closer look at the parasite and decide for yourself if it is a parasite or a artifact. So these are some of the parasites which were picked up in this case: the trophozoites of vivax, some gametocytes of falciparum, and this headphone shaped ring forms. And in falciparum, you have multiple ring forms inside a single RBC. So this is how here sorry, AI is coming to the help of a pathologist. So it is categorizing and grading our RBCs. So there is no confusion whether it is microcytic or a macrocytic or a dimorphic picture. It is giving you the visual evidence and making the pathologist work easier. It provides you the WBC differential count and platelet count, which will include Jane forms and clumps. So because the visual evidence is provided to the pathologist can report with more confidence. And the images are permanently saved on the cloud platform. So you can retrieve the images whenever and wherever you are from and whenever you want it. And it's helpful in your publications or in seeking second opinions. And definitely it saves the time of the pathologist, and it improves the TAT in the lab, and the pathologist can concentrate and give her or his time to more important things. and it definitely identifies the malaria parasite in less time. And early diagnosis means timely treatment, and the deadly complications of malaria can be prevented when it comes to malaria diagnosis. And pathologists need not sit in front of the microscope and check the slide for or review the slide for more than 20 minutes to half an hour before calling it negative. So all that time is saved here. It's made easy. So AI is not prone to fatigue. Hence, no chance of missing any crucial findings. Like if I am a pathologist and I'm given a slide of malaria to review at the end of the day at 6 o'clock, I wouldn't have the same energy and focus to pick up if there are any occasional, ring forms. I might miss it. But AI, since it's not prone to fatigue, it'll not miss any finding. So with all these points, what's the take-home message for you guys? AI100 is a game changer in today's diagnostic market, and it's an invaluable asset which makes the life of any pathologist easier. It saves her or his time, energy, effort, and it improves the TAT of the test. And telereporting is a huge advantage here. As stressed upon by the previous speakers, it bridges the gap, especially in the rural areas where there is lack of healthcare facilities, where there is lack of diagnostic expertise. You just have to put up AI100 in such places and tie up with a qualified pathologist or a hematopathologist who's sitting in a faraway metro city, and you can get your diagnosis on a daily basis. So telereporting is a huge advantage over here. And the data storage, it's hassle-free, as you all guys have already heard about it so much. So with all these points to ponder upon, I would like to conclude by saying that there are two kinds of pathologists, one who use AI and the other who wish they did. So this is what we believe at SigTuple. And thank you guys. I hope you've had a good webinar today. Thank you so much. I would be happy to take any questions if you have.
Thank you, Dr. Pavitra. That was a very good session on malaria and thalassemia. So now the forum is open for questions. A few questions have already been posted on the chat box. So one question, Dr. Bhagwat, I think it was directed to you. Can I just read out the question?
Yeah, sure.
So Dr. Badrinath from Bangalore had asked this question: what's the magnification you use to screen the slide? And will you not add an interpretation to the smear suggesting your differential diagnosis? And what further would you suggest the clinician? So these are the questions. And also he had asked about the how would you manage the unsatisfactory slides?
So, well, this question is, what's the magnification you use to screen the slide? Is this on manual microscopy or on digital? Because if it is digital, then it's 40x and you can zoom to 100x. That is what I know.
Yes.
Yeah, but if it is manual microscopy, I do it on a 10x. Most of my slides would go on 10x because I use the CBC analyzer, scattergrams, histograms a lot, and I look into it a lot. But and most of my slides would go on 10x. If I see something on 10x abnormal, only then I move further. But if you are asking about this digital microscopy, it is 40x to screen the slide. The second, we definitely add interpretation. Again, if it is digital microscopy, there are features in which you can put your impression, you can give your differential diagnosis, you can suggest. So basically, one has to understand that this AI100 is a microscope. So whatever you would be doing with your manual microscope, same everything has to be done with this microscope. The advantages that we have already discussed are many in terms of if you compare it with manual microscope, and the biggest which I feel is that you can see 100 cells at a go. You need not find them when you're trying to screen or report, and you can see the features as well. So that is what I would like to say the other questions also related to smear degeneration, sample degeneration, and bad smear. Again, this is a microscope. So if you are going to put in crap inside, you are going to get the same out of it. You will not get good results. And it holds true for manual microscopy. If I see a degenerated sample on a manual microscopy, I am not going to, I cannot report much on it. I have to ask for a repeat sample. If there are unsatisfactory smears, I have to make a repeat smear. And that is why another advantage which I had in Suraksha was the presence of automated slide stainer and maker. So that was really a big advantage. Rarely we had bad smears, although it took a lot of time for us to validate the stain. But once the staining protocol was validated, we used to get amazing slides, and the job was easier, whether it be manual or digital. And then digital is always better than manual.
Yes, thank you, Dr. Bhagwat, regarding the smear preparation, also on answering the digital Zoom question. So there were some more questions asked on the chat box. Dr. Samir, would you like to ask it again, or is it like, do you want an answer on that? Spirochetes, you had asked a question on spirochetes. Yes, there were a few spirochetes in the sample where Dr. Pavitra showed some cases. But spirochetes, as of now, we are still validating with more samples, and it will be definitely evident in the next upgrade. I would like to say that. And Dr. Badrinath again had asked about the RBC classification. It is done based on size and also the chromia, basically. That is how we divide the RBCs, even under manual microscopy. So any other question from anyone? The digital Zoom question has already been answered by Dr. Bhagwat. And also, one more question. Can this be used for, can this AI be used for histopathology? Not right now. We are coming up with a whole slide scanner as of now, but not AI on histopathology as of now. So any more questions? I'll take that as a no. Thank you. Thank you, Dr. Bhagwat, for this enlightening session, and thank you for your time. I would like to thank all the participants for enthusiastically participating and making this a very interactive session. Thank you all again. Thank you from the SigTuple team, and good night and a happy weekend.
Thank you.